So that doesn't. So it's a pleasure to be here. Thank you, Steve Higgins, for your wonderful hospitality. General Sorrell, thank you for coming. We both served on the Legacy Board Foundation. And to my treat and surprise, Zale Berry, a former resident of mine, shows up today after many, many years. Not looking a day older, so the state must be taking very good care of you. And thanks to the sponsors who made this possible. So this is what I'm gonna cover today. Our healthcare system. How do we do in terms of health? How do we do in terms of cost, access? Talk about the recent bill and its possible fate at the hands of our court, and work still to be done. But prior to that, I want to take some polls. So how many of you think the United States has the best medical care system in the world? It's interesting. When I gave that same question at UCSF, nobody raised their hand. When I gave it at a group of very conservative businessmen in San Francisco, about 2/3 of them raised their hand. How many of you, if your students have parents or if you're older, you are happy with your own medical care? And most people raise their hand. And that's the issue. Okay. The influentials are pretty happy with their own care. And that's a large part of why any possible change to that care has sparked so much controversy. How many of you, if your parents are dying or are about to die, want them to die in an ICU? In a hospital? Okay, very few, and I think that's true with most people. Here's the kicker. How many of you think that the 2010 Affordable Care Act was a good thing? Was a bad thing? Not sure. I'll bet most of you are the single payer folks, right? Okay. So what I'm going to do is take you through a pretty whirlwind tour, and you have a right to ask me, as I come to a conclusion of various things, what did I base that on? And partly it's the literature, and partly it's the experience I've had working in the system for a very long time. And my goals are to explain how we got here. You know, there's an old phrase, if you see a turtle on a fence post, it didn't get there by itself. So the system we have is not a result of an accident. It's sort of an inadvertent following of a whole bunch of choices. And then to challenge you to think how you might want to make things better. So in terms of health, the 30-nation OECD, we're anywhere from 19th to 25th in the usual markings of health. So we do quite badly. And if you look at the whole world, putting in countries like Costa Rica and Cuba, we're anywhere from 30th to 45th. So let me go a couple of samples. So this shows life expectancy from birth for women and men. And you can see that we're 22nd for all women, and we're 22nd for all men. Now, a lot of people when they see these figures, they say, well, the United States is such a heterogeneous country, and we have people of color and all that, so that's why we do so badly. So when you take away and make it just all white women, oh yeah, we're much better. We're 19th. White men, 19th. One of the places we do better is life expectancy from age 65. And there are 6 countries missing, so it's down to a denominator of 24 here. But we're still in the upper half. And there are 2 theories for that. One is that we've weeded out all the weak sisters who don't make it to age 65. And the other is, what's the only group in this country that's guaranteed to get access to all the kind of medical care they want? It's probably a combination of both of those. This shows life expectancy at birth in certain selected OECD countries. This is from the most recent Shattuck lecture that was just published a couple of weeks ago. And we can see here the US in red. And we started out a little more bunch, now we've fallen. In spite of all the biotechnical, wonderful things that have happened between 1960 and 2010. And you can see here that Austria moved up. They were actually one of the best. Excuse me, that was Norway. But everybody else is moving up faster than we are. The good news is that every developed country has a healthier lifestyle. You know, they're living longer, and that's true for us too. Life expectancy in OECD countries in 2001, and this hasn't changed much. You can see that we do better than a few of the countries, but look at all the countries that do worse than we do. Germany, Austria, Greece, Finland, et cetera, et cetera, et cetera. So if the metric of a good healthcare system is how well its people do in terms of life expectancy or infant mortality rates or deaths of mothers, we don't do very well. So there is some good news. I mentioned the first thing. Our recent life expectancy data was at an all-time high. The gender gap is narrowing just a little bit, and that's mainly because men's smoking rates came down pretty fast, and lung cancer rates for men have really come down quite a bit, lagging, of course, the decline in smoking rates. Almost all, and if you look at sort of different groups, white women do by far the best, although it's interesting, Asian women, who they don't collect these data for, actually have the highest life expectancy of any group. And when I told our medical students at UCSF that, and about a quarter of them are Asian women, they spontaneously cheered. I'd never heard that before. Black women were next, then white men, and then much, much worse, black men. Almost all those recent gains that we've seen have been in upper SES groups, and most of those come from the declines in smoking. So although we've gotten healthier, just like in our wealth, the gains are not equally shared among all elements of our country. And this is a table that I borrowed from this group that was in the Shattuck lecture, and it's worth spending some time on. It's a bit of a bummer for medical students, and I'll explain why, but it's very critical. So these are premature deaths. 40% of them come from personal behavior. Smoking, exercise, diet, drunk driving, decisions about sex. 30% of them stem from your genes, and not yet much we can do about them, although in many of your lifetimes that's going to change. 15% social. And this reflects that if you divide our country into 10 different deciles, ranging from the lowest to the highest, there's a stepwise increase in health with each decile, so that the 10th decile, the most fortunate, does better than the 9th decile. And why is this so? Partly it's circumstances, it's healthcare, but it's even when you correct for smoking and drinking and all that. And a lot of it has to do with being in control. So locus of control tends to be calming, not as stressful, and you live longer. And this has been shown in England and elsewhere too. The fourth area is the environment in which we live. So if you're poorer, you're not as able to go jogging because the streets aren't well lit. Often there's crime. Often there's a freeway that's near there. You're more liable to have an exposure to lead paint. You may live in a brownfield area, all that. So that's an issue. And finally, healthcare. And if everybody in this country had access to the best healthcare, the folks who did this study at the CDC estimated that we'd only get rid of 10% of premature deaths. Now, not to say we don't want health care, because we clearly do, but it's not going to get rid of that many deaths. Now, some people have said, I think they're probably right, that the previous argument that I outlined for you, in a little way, shortchanges our system. I know there's at least one person in this room who has an artificial hip, and whose pain went away and is able to do things like ski. We do much more of that kind of stuff. Hips, corneas, knees, ears, that don't translate into longer life, but translate maybe into a fuller life. So we may do better in that than other countries, but we don't have metrics of that. So this just breaks down this portion here and shows you that smoking is by far the largest cause of deaths, not just premature deaths. About 435,000 people, that's the number stayed about the same. This little line refers to about 200,000 of those 435,000 deaths they take place in people with mental illness or substance abuse problems because they have such a much higher rate of smoking. And John Hughes in the audience has been an expert on that, as are others. There are two lines under obesity and inactivity. One was a first paper that was published in JAMA in 2004 showing that almost as many people were dying from that problem as from smoking. Big headlines in the New York Times and elsewhere, being obese is about to overtake smoking. Well, people pushed back because the assumptions in the modeling were that older people who were overweight were going to die a lot earlier than it turns out they really do die. So they said, oops, let's take it down to 112,000. Even still, these two bars are the biggest of all these other ones, and yet you don't see much written about them, whereas you hear a lot about deaths in this area. So I don't see a lot of good news in our body politic these days, but I'm happy to be in the one area where I think things are getting better in smoking. In my state, prevalence is down to 11.9% of adult smoking, lowest ever. The only state lower than that is Utah. And why is that? Because they're half Mormon. So if you factored that out, the rate would be more like 18%. In our Kaiser program, they drove their prevalence from 12% to 9% in 3 years by essentially doing a full court press on figuring out who the smokers were and working really hard to get them to quit. Doctor smoking rates are down to about 1%. Incredible. Many more smoke-free areas. To refinance the S-chip program, we tacked on a 62-cent per pack federal tax increase. Smoking is being more stigmatized. A couple other things I could have on here is that if they withstand the challenge, cigarette packs in the fall will have pretty grisly warning labels. And the CDC has now come out with a media campaign about smoking. Any of you see those ads yet? Showing people with tracheotomies and amputated legs and those kinds of things. Yeah, you saw it. What did you think? It was disgusting, she says. All right. Thank you. So here's an interesting thing. We hear a lot about disparities and gaps. And Steve and I were just talking. They're mainly posed as racial and ethnic, but I think, and Steve I think would say yes, that they're really much more class than anything else. But as both the upper and the lower SES groups have gotten healthier, as I mentioned, the upper group has gotten healthier faster. As a result, the gap is widening. And so if we talk about closing this gap, there are two ways to do that. We could slow the growth in the upper group. That's not likely to happen. Or what everybody would like to happen is we could increase the health in this lower group. And that's an interesting challenge. So in terms of summarizing health status, we are doing better. The bottom of the developed world, I mentioned the functional status issue. Major declines in heart disease for multiple reasons, smoking, statins, healthcare. A lot of opportunities in the two areas that I mentioned. But the reason we really lag behind is attention to the poor. And so it becomes a social and a political issue. We can't get there with just doing better medical care, as important as that is. So we didn't do very well in health outcomes. Costs, we're number one. Nobody else comes close. We're almost at 20% of GDP, $2.6 trillion. France and Switzerland about 12%. Most other countries are in single digits. So we're really out there. And health insurance premium now is about $15,000 per family. So when you say, well, why don't they just buy it? A lot of families can't afford that. And as I mentioned, we get poor health value for the dollar. And because our political system is so dysfunctional, we're afraid to offer up the major issues which have to do with real changes in how care gets gets organized and who gets what. So we look for quick fixes, electronic medical record, pay for performance, research about which treatments work best. All those are good, but by themselves, none will really suffice to stabilize healthcare spending. And because there's so much power in that 20%, we don't take on the sectors that are driving it. The pharmaceutical industries, the device and insurance industries, hospitals, doctors, unions, and, dare I say it, academic medical centers. So this is just another graph. And you'll notice in 2012 it says it's about 17.7. We actually got there in about 2010. Last year, it didn't go up any higher than the cost of living in general, but the guess is that as the economy turns around, it's going to keep outpacing. And this just shows that we started a little bit higher in 1980, but we've gone up much faster than any other country. All the countries are wrestling with the same thing. Our appetite for healthcare is greater than our capacity and willingness to pay for it, but we're going faster than any other country. It didn't escape the notice of the Harvard Business School. So this just shows these other countries, US in red. And here's a graph from the Harvard Business School a couple years ago. This looks at healthcare spending, and this looks at estimated life expectancy. And here we are. And Harvard Business School said, we're not getting terribly good value for all this money that we're spending. I don't think you needed to go to Harvard to figure that one out. So why do we spend so much for healthcare? I've listed a bunch of theories on several slides, and let me go through them very quickly. Do we have more doctors? No. We actually are probably in the lower third of the OECD countries in terms of doctors per population. But we have a much higher proportion of specialists than any other country. Is it how we pay doctors under fee-for-service? Yes. We have tremendously high incentives to do technologies as opposed to hands-on care. Do health worker incomes get more money? Yes. Starting from the director of the hospital, but going down to LVNs and janitors, everybody working in the health system makes more money compared to the rest of the population than happens in, say, Europe. Do we have more hospitals? No. Like with doctors, we're probably in the bottom third. Do we stay in the hospital longer? No. We're out quicker and sicker. But we really, like we have a lot more specialists, we put a lot more of our resources into ICU beds, tremendous amount more. And we do a lot more stuff, especially imaging and other things, compared to other countries. Practice style, Jack Wenberg at Dartmouth pointed out that there are tremendous variations, and in general, the northern tier of the country practices a leaner, more efficient practice of medicine than the southern tier, Florida probably being the case history for the worst, as well as Texas. It's a lot more costly to bill and to run things because we don't have a single payer. The typical big hospital may have 400 different health insurance companies, each with a different form, and they run algorithms to try to maximize payment. So that's different. When you talk to doctors, they always single out malpractice, including the fear of being sued. And studies have shown that that is a feature here, but it's relatively true. It's about $54 billion annually on the denominator of 2.6 billion. Excuse me, 2.6 trillion. So even if we saved all of that, we'd still be at about 17% of GDP. Everybody says, well, we got an aging population and older people consume more healthcare. That's absolutely true. But we're actually aging less quickly than Japan, Sweden, Norway, and others because we're bringing in so many immigrants. So compared to the other OECD countries, we have a relatively younger group of people. Do patients want more? Yeah, they really do here. They really do. And it's shown in alternative therapies, and care at the end of life, everything. And that's a huge factor. The economists say we need more competition according to costs. That's not how we got there, because none of the other countries that spend much less than we do have competition for cost. but it may be a way to get us out of this. We don't know. Low investment in IT. Again, some people do a silly argument. They say, look at the UK. All their doctors use an electronic medical record. They spend a lot less than we do, therefore that's the reason. Well, they always spend a lot less than we do. They introduced the electronic medical record a couple of years ago. There are a lot of good reasons for doing it, and it may save us some money, but it's not clear yet, and there was a recent study that showed that it may actually make it easier to order an imaging test. Fraud, yeah, we do that, and it would be better if we did less. So the Institute of Medicine recently took a look at excess medical costs, estimated they're about a third of the total of the 2.6 trillion, and broke them down in the categories of unnecessary services, so the surgery didn't have to happen, inefficient, so surgery that happens in the hospital that could have been done on the outpatient, or an expensive drug as opposed to a cheaper drug, excess costs in running the system, prices that are too high, missed opportunities to try to do a prevention. Phil and I were talking about this with people with chronic heart failure, fraud. So all those add up to that. And this, I'm just going to show you a couple of reasons why we're so expensive. So this is number of MRI units per million persons, and we tend to use them, and they cost a lot. Hospital expenditures per day. Coronary angioplasty. We don't have a lot more heart disease. We don't have as many as some of these countries, but we do a lot. No one knows what the right number is. And there's some that probably ought to be done that weren't, but there are probably some of these that shouldn't have been done. And this just shows about Canada. I remember your husband's from Canada. And showing that in the ages 65 to 69, the ratio of procedures between U.S. and Canada for angioplasty, bypass surgery, and surgery on the carotid were a little more than 1, but not double. But over 80, we do 7 to 8 times as many. So when you hear about rationing and death squads and all, we're so far, compared to other countries, from doing that you should laugh at it. This was a Harris poll that I did when I was on a sabbatical in England a couple of decades ago, where we asked people in these 5 countries, if your doctor said you had an incurable fatal illness, would you accept that or seek a second opinion? And you gotta love the Brits. You know, it's, well, love, it's been a good life, let's have a cup of tea, you know. That's it. And here, these people must be in Idaho or maybe northern Vermont, and the other countries are sort of in the middle. So we really don't go, you know, as someone said, rage, don't go into that good night, rage against the dark, and we rage. So why can't we keep costs under control? Well, part of it is we don't want to have limited choices. Part of it is the industries, who are terribly potent, and the hospital and the medical sectors, and that patients want more, and the new technologies, and our political system, which doesn't permit us to take on controversial issues, and how polarized things are, so that it becomes really sensational. The worst part of it for me was in the debate on the Affordable Care Act, when Senator Grassley, who knew better, accused Congressman Blumenauer, who wanted to have palliative care, a discussion of palliative care, be a benefit in the House version of the ACA, and this got morphed into death panels and killing Granny. And to my shame, no medical group stood up and said, that's ridiculous. This is just something that everybody ought to know about. So some people say, hey, what's so bad about 20 or 25% of the GDP going to healthcare? When I'm sick, when I'm hurting, when my family's ill, I want the best. And the answer is opportunity cost. So out where I am in California, we've gone from 1st in the nation to 49th in the nation in per capita spending for students, K through 12. And a big chunk of that is healthcare, and a big chunk of that is prisons. They've really taken the money that might go to schools. I happen to think the global climate change is a huge issue. we don't have the money or the kind of political consensus to take that on. Our competition doesn't have to pay for health care in the way that General Motors does and other worthy causes. And business is now, is now pushing back the same. It costs too much. We don't want to keep the promise we had to cover our retirees because we can't do that and keep our bottom line. The biggest single cause of labor disputes is that when the industry tries to take away the health benefit, makes them pay more, raises up the copay. And all the public programs, so Medicare, Medicaid, the county hospitals are all fighting for resources, particularly since we politically can't raise taxes now. The federal deficit, you all follow that issue. Higher insurance premiums mean more and more companies stop covering people, or people decide they can't do it. This is the biggest personal source, the biggest cause of personal bankruptcies. And this will be the defining health issue, I think, for the next three decades, because there's a fundamental problem. People want more health care, and it's hard to pay for it. And we're not willing to ratchet down how costly it is. So maybe the Medicare cost crisis might force some things to happen. How we pay doctors and the SGR, we keep moving the resolution of that down the road, but we have to face up to it at some point. The Medicare deficit. At that point, in 2017, Congress will have three fundamental choices. They can raise taxes, they can cut benefits, tell Granny, you can no longer get an annual physical, or you can't get these drugs covered, or you can't get these tests, or reduce what they pay the healthcare sector. And it's pretty easy to say that this is going to win. In other countries, they use a bunch of different things. Global budgets, probably the one that works the easiest, where you say, I'm not going to decide as a government who gets what. I'm going to turn it over to the healthcare sector. You've got a fixed budget, work with it. In most other countries, they have, or many of them, the primary care workforce are the gatekeepers, but because the U.S. doesn't like choice taken away, that doesn't work very well. They restrict covered services in a few countries. The technology is often restricted until it's clearly shown to be of benefit. Patients can supplement, like in England, the insurance they have through the country, and they manage chronic illness. So this is a cynical slide, but what are the priorities of our country? We want the best, we want it right now, we want choices, we want someone else to pay for it. If we can't get it, we'll sue. Most countries pick two of those, generally not this one, and we have all five, which shows you how tough a management challenge this is going to be. So let's move on now. We've covered healthcare outcomes, we've covered costs, and now let's look at access. So I would suspect that the people in this room, at least most of you, have some of the best medical care on the planet. If you've got an insurance card and you're intelligent, you can really get very well taken care of. But we also have some of the worst systems, in that we've got people who don't have health care, or who live at great distance, or who live near not very good kinds of facilities. And the major access barrier is not having coverage. And there are about 52 million people, almost one, or a little about 1/6 of the population aren't covered. 60 million others are underinsured, which means they have to pay a lot out of pocket to get health care. The percentage of workers who are covered where they work privately with health insurance is gradually going down from about 69% about 10 or 12 years ago to about 61% today. And if the Affordable Care Act doesn't go through, that number is going to keep going down. More and more expenses out of pocket, and there are other barriers too. And there's a different salience, as I'll come back, for the two parties. Who are the uninsured? If you break out this group, you'll see that a lot of them are very poor. A small amount have incomes over 40% of the federal poverty level, about 10%. And a lot of attention is on, well, these people, they're getting kind of a free ride. But they're not a lot of the uninsured. So I wrote in 1996 a sounding board in the New England Journal asking, why do we tolerate such a large number of the uninsured? And I went over all these 7. I'm going to talk about the 8th in a minute. Some people say the numbers are, it's not really 52 million, it's 49 million. Uninsurance is often temporary, that's true, but the same people who go in and out of it are the ones who are most kind of handicapped. And if there are 52 million uninsured at any one time, there's probably in a year maybe 70 million who are uninsured. Many choose to be uninsured. The young people in the audience probably know college classmates who are going bare, and they have the refuge of either getting on a Medicaid programs or mom and dad are going to help them. But that's not that many. The uninsured get care anyway. Well, they do, but not great care. If a woman who's uninsured gets diagnosed with breast cancer, it's much more liable to be stage 4 than a woman who is insured. We can't afford to expand coverage. Yeah, we can afford to fight wars. We just have chosen not to expand coverage. Number 6 and number 7 are really critical. So I was given a talk in Canada after the Clinton Health Plan program failed. And I had to explain to the Canadians that in this country, a lot of us don't trust our government. The Canadians pretty much do, and they kind of looked at me blankly. But it's a feature, not just recent. It goes way back to the founding of our country. And we set up a constitution to make it harder for government to do stuff. And what I should have mentioned when I wrote this article, I don't know why I didn't think of it, but the poor don't have any clout. They don't vote in a proportional number, and they don't make a donation to PACs. So this just shows in a recent IOM study what difference it makes to have health insurance. So are there problems getting or delays getting adequate medical care for asthma, for depression, for diabetes, or for heart disease? And you can say it's 2 to 3 times as hard to get them if you don't have health care coverage. So let's move to the politics of today. The Affordable Care Act. When the president and his colleagues were working with this, they had 3 challenges. How to expand coverage, actually 4. How to pay for it. Should they do something else? And doing that in a fiercely partisan background. President, remember, in 2008 campaigned on, I'm going to get some kind of national health care through. In opposition, there was a very influential memo by William Kristol when the Clinton health plan looked like it was going to get support from moderate senators such as Dole and Chafee. And Kristol wrote to his colleagues, said, don't support a Democratic health care plan. It'll do for them what Social Security did for FDR. It'll entrench the Democrats in power. Whatever they offer, take a step back. Pretend to compromise, but don't do it. And his memo won the day. And so the Republicans kind of were unified in not wanting to have any kind of a Democratic health care plan. The Democrats, on the other hand, were very fractured. Some wanted single payer, some wanted some kind of a choice or market mechanism. At the same time, in 2010 or in 29, there was a massive bailout of Wall Street and the auto industry, and people got worried that government was swinging its weight around. This isn't the country that I like. This is a government that's doing more than it should. Federal deficit was going up, a lot of other stuff on the plate, and a lot of the people who are in the game in healthcare didn't want the change to happen, but they were less opposed than in '93 because of some horse trading. So organized medicine didn't come out as much opposed to the Affordable Care Act as they did to the Clinton Act, because basically the president cut a deal with them, saying we won't take a big whack out of doctors' fees. Same with Big Pharma. And business was worried because the costs were going up so much. And even though business hates basically to have government run stuff, they also realized that they were paying more. So, and health insurance, which really opposed the Clinton plan, was seeing its customers go down from 69% to 61% and on its way down. So they thought, well, this will be a source of new healthcare customers. The Catholic Church was split along ideological issues. But in general, the opposition was not as fierce as it was towards Clinton from outside folks. I was surprised after Kennedy lost his seat and the Democrats lost their veto, their filibuster-proof Senate, that the bill passed. Democrats in general were very supportive. Republicans were furious. The bill is very complicated because basically the House was persuaded to pass the Senate version that had been passed when Kennedy was a senator. The idea of that was that it was an incomplete bill and they'd work out all the details in a reconciliation session between the two houses, but now they couldn't do that. So a lot of stuff was, we'll figure this out later. And of course, as you know, it's been actively challenged. So what did it do? It covered 32 million new people, 50% under private health insurance, 50% under expanded Medicaid. It raises the national coverage level from about 83% to 95%. And in order to make his fiscal goal, the president deferred expansion until 2014. When Johnson signed Medicare and Medicaid, he said, as of July 1966, everybody over 65 was going to have this card. And he signed it a few months prior. What the president did is he signed in 2010 and said, in 4 years, you're going to get something. So people didn't get the benefit. There are other things that they got, but it didn't hit most people. But he delayed that because they had to raise some money in the interval to make it a budget neutral. You've heard all about the individual mandates, although some people think the penalties are too low. And they have to, firms with over 200 people have to cover. Right now, Walmart, when it hires its low-priced people in many states, gives them a Medicaid application form. So the states, taxpayers are subsidizing Walmart. It gives extensive income subsidies for low-income families. So the poorer you are, the more your insurance is subsidized. It penalizes employers and individuals who don't sign up. Expands Medicaid for everybody under 133% of the federal poverty level. Now your program here is probably at the 400% level, but in many of the southern states it's really, really low. So this is going to disproportionately help southern states which have the highest rate of uninsured. And the government will cover those expansions until 2020, and then they'll have these exchanges in the states so that high-risk people who want to buy healthcare coverage won't be singled out because their rates would otherwise be very, very high. So the things that they got prior to 2014, which are very popular, are pre-existing conditions. If you move from working at this medical center to, say, Dartmouth, and Dartmouth has a different healthcare coverage, and your kid has asthma, they may disallow asthma care for your kid because it's a pre-existing condition. And what the bill says is, no, you can't do that anymore as of 2012. Insurance companies must pay more for benefits. They can't keep as high a profit. Kids can stay in their parents' coverage till age 26. That was very popular with a small group of people. And it used to be that there was a lifetime cap. So if you were on an expensive drug or whatever and you hit $1 million total, they could say, we're not going to pay more for your cancer. So they did away with all these, all of which are pretty popular, but not sufficiently popular to increase the popularity of the bill in polls. How to pay for it? 50% was going to come through spending cuts, Medicare Advantage, medical savings accounts, limited Medicare growth, less payments to safety net hospitals, and 50% from new revenues, some taxes, and expensive, and the Goldman Sachs plans, and other features were put in as pilots that could lower costs. And I won't read all these. These all are really great in theory. Translating them into action is going to be a lot less simple than you would think from reading the bill or seeing them. They're all good, but taking them from pilots to scale may be very challenging. So I'm going to go through challenges to implementation of the ACA. And the implementation details are really tricky. So we still haven't figured out the exchanges, and some states, those that don't like the ACA, are saying we're not going to do them, so then the government's going to have to come in and take over. Congress, at least the House, is going to try to restrict the federal dollars that can be done to do all this, because they hate the party in charge of the House hates this bill. So it may be difficult to do that. How does the IRS collect the penalties if the individual mandate passes the court case, or from the companies that don't pay? The states can define what the benefits are. Funding of the demonstration projects, some of them, for example, the Independent Payment Advisory Board, the House has voted to zero it out, so it hasn't been able to hire anyone to work there. This is one of the major cost containment strategies. We had a spectacular CMS chief, Don Berwick, a visionary person who was nominated, couldn't even have a Senate hearing because people felt so hostile towards him. So he was given a recess, a appointment for 18 months, and he is now gone. So there's legal challenges. You know about the case, which happened last week, the hearing, and these were the arguments. And it's of interest that 26 attorneys general, not Vermont, Bill, I don't think you were, in fact, you were for the government's role, but 26 attorneys general challenged this. So more than half of the states said this is an unconstitutional law. All of them were Republican in their politics. The going wisdom is the legal challenge is more serious than the Medicaid challenge. If the individual mandate is overturned, then it's going to be hard to cover the 16 million covered privately because you're going to get adverse selection. People who think that they're healthy won't sign up, so you'll make it a more sick pool. But you could still expand the Medicaid unless the court rules, and there were a lot of questioning from the conservative justices that, well, if we overturn the mandate, shouldn't we just overturn the whole bill? So most people think the Medicaid expansion will be upheld, and on the individual mandate, the going wisdom, especially after the tone of the hearings, is that it will be overruled on a 5-4 basis on the kind of predictable lines that the judges have been ruling in the past. Some people think that either Kennedy or Roberts might swing, but I wouldn't bet your firstborn on that. And this wild card that they say, this is sort of a technical issue, that you can't rule on a tax until it's actually levied. Neither the government nor the states who were suing wanted to really pursue that line. They got an other lawyer to come in and do it, and there wasn't much support at the hearing. So nobody knows what's going to happen, but I think it's unlikely that that's going to happen. And so people think it's going to happen in June. If I were to bet now, I would bet that the mandate will be overturned, and so this whole thing falls apart. But I don't know that for sure, obviously. So one of the questions they ask out in California is, why do Republicans oppose health care reform? And there's really several reasons. One is, if you look at the primary voters and ask where health care coverage is on their top 15, at best it's number 15. So it's just not salient for their voters. There's a philosophical opposition to government actions to solve social issues. There's the belief, and it's very sincere in some instances at least, that charity from the private sector should provide the access that's needed. And the paradox that the states that would benefit the most are the states that have the most opposition to the ACA. And there's a lot of race that's involved with that too, I'm sad to say, because there's a disproportionate number of poor African Americans in the South who aren't covered. So, politics. In 2012, there will be more voting. We're going to vote for a third of the senators, all of the reps, and the president. So let me outline 3 different scenarios. if Romney wins, the Republicans keep the House and they take the Senate, and that's not unlikely because there are 33 open seats, only 10 of which are held by Republicans, 23 by Democrats, and some of those, such as Nelson and Omaha, et cetera, are going to be very difficult for the Democrats to capture. So if all those happen, ACA is a goner, and they're probably going to block grants to states for the Medicaid programs, which means then that right now what Medicaid does is says you're entitled to services, and you just got to pay, the states, you got to pay for those. If it's a block grant, there's a fixed budget, and so there will be fewer services as well as lower payment rates. In the status quo, the Democrats keep the Senate and the presidency, Republicans keep the House, and the Supreme Court says the ACA is okay, then it's going to be sort of the way things are. Tooth and nail, gradual, sort of folding in, probably later, maybe kind of messy. And the fact that it's messy is maybe going to look at, maybe people are going to say it's not such a good deal. And if the Republicans keep the House and get the Senate, and our president gets a second term, then the implementation is going to be even slower. So your guess is as good as mine as to what's going to happen. Other uncertainties in healthcare reform is what about those still lacking coverage? And it's an interesting article in the New York Times yesterday that the Republicans are beginning to say, well, what's our plan if the ACA goes away? And it's going to be primarily aimed at higher end folks, but giving them choices, giving them options to a catastrophic health insurance premium, which means you pay a lot lower premium, but what you get as benefits is going to be less. Can you pass the political issue of you do a study and you show that it's more cost effective with back pain not to do an image in the first 6 weeks unless there's nerve weakness or weakness of the muscle, and you put that out there? The industry is going to push back. We saw that with the statement that a mammogram in a woman under 50 should be limited to those who have a special reason for it. And the radiologists, the women's movement, and the cancer folks just went furious. And the secretary of HHS said, oh no, we're not going to do that. Care at the end of life and palliative care, we sort of talked about that. That's a huge issue for us. And can we truly bend the cost curve? So final thoughts. I don't see us neatly wrapping this issue up and going on to something else. I think we're going to be pushing and pulling it for many, many decades. The politics of it are toxic because the politics of our country are toxic, and healthcare is such an emotional issue. And it's so easy to get inflammatory sound bites, and both parties have done that. I mentioned the poor health status and no easy solution to fighting costs. I think I've mentioned these first two bullets. Ultimately, like we do in so many things, the courts are going to be major arbiters of what's going to happen. And my sense is it's so political that issues of campaign finance and voter turnout may actually be the final factor in figuring out what kind of a healthcare system our country ought to have. So we are in evolution. We're going to continue to be for some time. And as Betty Davis once said at the end of a movie, buckle your safety belt. It's going to be a rough ride. Thank you. Thank you. So I think there's some time for questions or comments. Yes.
So going back to your Michael McGinnis slide about the determinants of health outcomes.
Yep.
On the public health side, we have seen some success in reducing risk factors. And where do you see spending, investment at the federal level going public health promotion.
Okay. So what about public health as a way, spending in public health as a way to impact on these issues, right? Or the previous one? Well, okay, either one. This administration, particularly in the Stimulus Act, put by previous standards a fair bit of money into the CDC and elsewhere to work on these. They are very attractive to Congress as a way to cut because there's not a lot of advocacy for them. So public health suffers in advocacy in comparison to organized medicine, hospitals, academia. Medical academia, the AAMC et al., doesn't really support the kind of programs that you've been talking about. So if the economy turns around and if this president stays in office, then I think we're liable to have some money. The second part of your question is how should that money be spent? And there is no one single solution. I'm going to move on out of here. There is no one single solution to any of these, but most of them would benefit from multiple strategies, as has happened in smoking, was happening with overweight, and there are a lot of different groups, Robert Johnson Foundation being one of them, that are working in this area. If the Republicans win the presidency, I think you're going to have a lot less enthusiasm for public health in general because it's public and it's government and it can be caricatured as the nanny state, and the answer is let's not put warning labels on stuff, let's not put calorie counts on, let's not have the FDA do stuff. So I think it's a very much of a issue of politics. Yeah.
First, I want to thank you for your comprehensive and thoughtful perspectives on many issues. I guess I have kind of two questions. First one, if you did mention just in passing, the academic medical center, you had something you almost wanted to say there about why they may not be on the right side of every issue here, in the sense of maybe holding some things back. I wonder if you could just comment on that a little bit. And the second thing is, it's hard not to focus on Japan, but there's so many slides you showed. So the question is, certainly they have the longevity in Japan, so the obvious question is, are they happy in Japan? And if they have the longevity and they're happy, the question is, how did they pull that off at lower costs? And was some of it because they don't enjoy all the choice?
Okay, so two questions. One was, how does Japan do it? Because they spend a lot. They don't spend very much, and they live really long. And are they happy? The U.S. in general is less happy about its medical care than most other countries, including the Canadians. So though you wouldn't know that from the way we feature the odd story about the Canadian who has to go to Detroit to get a bypass surgery or a hip. Japan stands out in two ways. They have a very high rate of doctor visits because doctors make a lot of their money writing scripts for drugs. They also have a very high rate of imaging. Really beyond that, though, it's a parsimonious style of practice. And they don't stock their hospitals as much. They don't expect as much from the healthcare system. Up until recently, they wouldn't tell their elderly relatives that they had cancer. So a lot of this is cultural. The second question is, what are my feelings about academic medicine? So I have a love-hate relationship with academic medicine. Academic medicine's been good to me. I work at a wonderful one. They're fountains of bringing new technologies into medical care. They train the doctors of the future. But as a collective, what they argue for are really two things. One is more basic research, and second is more high-tech medicine. And what they teach the students, maybe not here, but at most places, is the best medicine is the one that does the most. And so all our doctors are leaving thinking that if they don't do the X scan, they're really deficient. So I haven't seen academic medicine weighing in on a lot of the social issues of medicine. And they've had an antipathy, either implicit or explicit, to the kind of public health issues that you were asking about, seeing those as either second rate or not as critical or a diversion of resources from fundamental basic research. I also think, and it's not a surprise, and it's what anyone would do, that they have oversold the results of basic research. So I remember in the 70s, we were going to have a war on cancer. We're going to double the NCI budget, and cancer is going to be gone. We're going to clone the genome, and we're going to have all this personalized medicine, and that's going to change things. And it may happen, but it's taken a lot longer than we thought. And it's really hard for a dean or a chairman to take the long view when, like in a stock, you're judged on how you do each quarter. So I don't think we can ask them to do it on their own, but I think it would be nice if they had more support. Yes?
Thank you again. It's wonderful talk. A lot of changes seem to come about because of grassroots activism. What power do you think patients have in bringing about some of the necessary changes in both cost control, doing having care that's effective but not harmful, and other things related to how healthcare can change and be more equitable for more people?
So the question is, a lot of changes come out at the grassroots level. What can activated patients do? We had a huge example socially of here. The 80% of the people who don't smoke said basically, I don't want you smokers getting your secondhand smoke in my lungs. And that's really led to smoke-free airplanes, smoke-free bars, smoke-free restaurants, smoke-free workplaces, and the tolerance of raising taxes, even in states that normally, in a political sense, don't want to do that, but raising the tax of a pack of cigarettes. The grassroots activism has been very potent in the United States, but usually in wanting more in illnesses. So the women's movement has been spectacular. They actually pushed through getting coverage for bone marrow transplant for breast cancer when ultimately it was shown to be a harmful treatment. But when the health insurance companies tried to say there's no evidence for it yet, the women advocates took their case to the Congress and others, and it was overruled. Our country is much more conflicted about care at the end of life. Part of it is we're such a big country, and many of us are separated from our parents, so we feel really guilty about that. I have a friend who was a big-time doctor in Manhattan, and two of his patients were Jackie Kennedy and Richard Nixon. And where do you think they died? They died at home. So most people, and when I took the poll, none of you wanted you or your parents to die in a hospital. But a lot of people are very suspicious, less educated people, and they can be fanned, this whole thing of death squads and panels. So I think the problem is with the media. And I don't think the medical profession, now the ACP, you might want to mention what the ACP is doing. The ACP has come up with a list, and it was in the paper yesterday, of 15, I think it is, tests that you don't necessarily have to do. And that if you didn't do those, you could save money. But there will be some pushback from that. And I think the medical profession, I hope that the next time there's an accusation of the death panels, that the ACP or SGIM or the AMA or AAMC will stand up and go on the talk shows and say, you know, that's not really true. Here's how it works. So the public can be very potent, but right now I think they're more worried about things being taken from them. And they're often fanned by unscrupulous people in the political world, and also by the talk shows, which want the sensation-grabbing, you know, the crawl headline, which isn't nuanced. And a lot of this stuff is nuanced, and we don't do nuance very well as a society. Bill.
Yes, Steve, you mentioned Medicare going into deficit in 2017, Social Security, similar situation with the baby boomers.
That's 2037, right? The Social Security, I thought. Yeah, something like that.
Something like that.
Yeah.
But I mean, with the baby boomers moving into retirement, sort of going to be an accelerating pace of that. But I wonder how the whole guns versus butter debate and our American self-concept in terms of our role in the world as the cops or whatever, does that looking down the road, do we see generational strife in this country and a huge sort of problems of self-identity as Americans to the extent that we need to move more into spending on butter and consequently our own self-view suffers?
So two components to Bill's question. One is, Will we have intergenerational strife? Because as a society ages, as a larger and larger segment of our society is over 65 that gets more and more money for health care and for social security, will there be an intergenerational? I'm not sure it's going to happen because the young people in the audience, you're kind of glad that you don't have to pay for mom and dad's health care, and that they're going to get some money that they can pass on to your kids to go to college. So I don't see it quite as striking in that. What I do see is the voting pattern, that the young people don't vote and the older people do, and the older people are voting as a block, and the older people are very concerned. The reason that the Congress swung in 2010 is that older people were really concerned that the ACA was going to take chunks out of their Medicare program. So there was a self-interested voting there. The issue of where do we see ourselves as a country, it's really a fascinating one. We've always felt that there was sort of a manifest destiny. God had smiled on us. It's in our national anthems. God shed his grace on thee, that we're going to have it all. And we're now in a time when we are confronted that we can't have it all. We're going to have to accept limits. That would be a wonderful way to have a political discourse and talk about trade-offs. It's not safe to do that now because both parties yell, gotcha. And so it's got to start at the regional level. You all have done a great service in passing a single-payer health bill, although how you get there into implementation, I don't know. I'm going to follow with great interest. So I don't mean to preach to this state, which I think probably does solidarity more than most. It doesn't hurt that you're only 700,000 people. I come from a state with 34 million, so it's a little bit different. But I think it's a major challenge for us. And on some days I'm optimistic, and on some days I'm not, and I hope the optimistic trials. And I think we're getting the signal that.
Well, we have time for one or two more questions, and then we're going to have a reception over in the health sciences lobby.
Okay.
So we can continue there.
I don't think we have one or two more questions. Oh, yes, Ray.
Given the economic realities of the rapidly rising cost of healthcare, I'm surprised it's not more of a bipartisan issue in terms of trying to come up with a solution. What I was wondering is, when you give this sort of talk to a room full of businessmen or Republicans, what are the alternative solutions that are out there to try to solve this problem?
So the question is, shouldn't both parties want to keep down medical care costs? In their heart of hearts, both do, but it's not safe for either to do it. So when one puts his head out of the trench hole, the other shoots at them. And really, that happens.
That completely baffles me because it's an important problem. All of those graphs you show are things that people should pay attention to.
That's science.
So let's take the recent Ryan bill. And the Ryan bill has a lot of stuff in it that I think a lot of Democrats would sign on to if it hadn't taken away from stuff but not raised taxes on the wealthy. So it's the packaging. And I think each side is now very suspicious that they can't make a compromise because their base won't really support it. So politics is the art of compromise. That's what used to happen. LBJ and Sam Rayburn, a bunch of people would get in a room, it was usually smoke-filled, and come out with a compromise. And what's happened is that each party, but especially the party that's more kind of conservative today, has just swung way over. And you're only challenged if you're a Democrat in a primary from the left, generally. And if you're a Republican, you're only challenged from the right. And therefore, to move to the center to compromise can cost you your office. So you've seen a lot of people like Orrin Hatch, Governor Romney, who used to be sort of moderates, have now, out of self-protection, swung over much more conservatively. And some of the Democrats have done the opposite from that. So I think it's a process issue, it's not a substance issue. But substance can really dictate process.
Maybe one more question.
Yes?
The memo about the Republican strategy
Yeah.
seems to me to trump any of the arguments about, even about their political spectrum. If you can't vote for health care if you're a Republican unless it's a Republican plan. And you can't vote for the taxes or tax reduction if you're a Democrat, unless it's a Democrat plan. And so without a supermajority in both houses, essentially nothing gets done. Because of that, the prime directive not being to solve the problem, but to keep your party in power. And, do you see it differently, or is there a way to manipulate that other than to try and drive one of the parties under?
So you summarized it very nicely, that each party is really dug in. I think one of two things will happen. Either it'll keep being trench warfare, or there'll be such, if the economy had really tanked, I think that, but now it looks like it's coming back. So we may keep muddling through for a while. Bill, do you want to comment? You follow politics more than I do. Do you?
I'm in the primary.
Okay. It isn't safe, and I must say, I take my hat off to anybody who's, I'll end with this maybe, to anybody who's willing to run for public office and take the exposure and the insulting and all that goes with that, and still do it, and the lousy income and the headlines, and not so much in this state, I would guess, but to still do it anywhere. They're the real heroes, in spite of the fact that they can be fiercely partisan. So on that happy note,